Good afternoon and welcome everyone to this patient-focused webinar. I'm Katie Davis from Insightech and I'm pleased to be part of today's virtual educational event. Please be patient as we take just a few minutes to allow everyone to get signed on. The presentation will begin shortly. Good afternoon, everyone, and thank you so much for joining us this afternoon. My name is Katie Davis from Insightech, and we're just going to take a few minutes to allow everyone to get signed on, and the presentation will begin here shortly. Looks like we have a great number of attendees signed on, so let's begin. The goal of today's presentation is for educational purposes. We're very fortunate to be hearing from Dr. Krishna and Dr. Roque from the University of North Carolina at Chapel Hill as they discuss treatment options for essential tremor, an overview, diagnosis, and how to approach your doctor. As questions arise during the presentation, please utilize the Q&A button located at the bottom of your screen. We'll have time after the presentation to answer the questions that are asked within the chat. Let me begin by introducing you to today's presenters, Dr. Krishna and Dr. Roque. Dr. Krishna is a board-certified neurosurgeon with expertise in functional neurosurgery and neuromodulation. Dr. Krishna treats patients with movement disorders, including essential tremor, Parkinson's disease, and dystonia. He is an early adopter of focused ultrasound technology and is considered a thought leader in the field. As a surgeon scientist, he focused on research to optimize the focused ultrasound technique to improve patient outcomes around the world. Dr. Roque is a board-certified neurologist and movement disorder specialist with specific expertise diagnosing and treating multiple tremor syndromes. His clinical and research focus is on the improvement of tremors through both traditional and innovative methods, seeking out quality of life initiatives for patients with movement disorders. He serves on multiple regional and national forums aimed to improve outcomes for tremor management. Welcome, Dr. Krishna and Dr. Roque, and thank you so much for presenting to us this afternoon. The floor is all yours.
Thank you, Katie. We appreciate the opportunity to connect and be able to present this to folks who are interested in learning more about the treatment options for patients with essential tremor. And today's webinar is packed with a lot of information. And my partner, Dr. Roque, is going to go into the details of diagnosis of essential tremor, current treatment options, and how to approach your physician. And so it's an excellent webinar, great content, and we really hope that it will be useful for you as you think about your journey in taking care of tremors. As we get started, I thought I would put together a few slides for you as a broad overview. I'm a surgeon, as Katie talked about, and I specialize in taking care of patients with tremor syndromes using different kind of surgical techniques. I'll begin by thanking all of you for joining us. This is very exciting. This is one of the highlights of my day. As I reviewed my schedule for the upcoming week, I was excited about this time slot for this chance to connect with everyone, not only from North Carolina, but beyond. And an active participation from patients in this makes this very exciting. the stories that you share, and as you become a part of the dialogue, that's the most exciting part. And as we learn about you, your challenges that you face because of tremors and other symptoms, they inspire us to create solutions that fit what your needs are, and allow you to do things that you aim to do in your life. And again, your trust in us as a patient care team is what motivates us to continue to improve patient care as we embark on this journey together. And the biggest joy that comes to us is when our patients feel better. And this is the underlying theme for all of us at UNC, where it's a patient-centric team, and the goal is to help patients feel better, and that's what brings us the most joy and satisfaction. In general, as we think about surgery for movement disorders, there are two main buckets. And one bucket is the stimulation bucket, and the other one is ablation bucket of treatments. In stimulation, we do a surgery called deep brain stimulation. So it's a brain stimulation technique to improve patients' tremors. And not only tremors, it's very effective for other kind of movement disorders. And the short form for deep brain stimulation surgery is often DBS. So you heard this term quite often. And this surgery can be done either asleep or awake. And so the treatment can be delivered when the patients are awake and you do testing, or patients are asleep for the procedure. In the ablation bucket, there are two main treatments: focused ultrasound ablation and radiosurgery, most common of which is gamma knife radiosurgery. And we'll talk to you in more detail about focused ultrasound ablation. There are some exciting advances in our field, and I thought I would highlight for you what those exciting advances are. And so one of the key advances in our field is the use of robotics for precise surgical treatments. And so here is a picture of a robot called the ROSA robot that we recently acquired here at UNC, and we use this treatment to precisely target different brain regions to be able to deliver therapeutics for a variety of neurological disorders. Combined with this, we then think about using personalized medicine that fits to each patient's anatomy, anatomical details, and structure. And so specific to tremor surgery, this personalized medicine looks like this, where we use a advanced imaging technique using MRI to visualize the brain areas of interest. And so in this picture, you can see a MRI picture, which is shown in gray scale, and superimposed on that are two fiber tracks that are shown in red and blue. These are the fiber tracks that are very important in maintaining the motor and the sensory control of the body. And right adjacent to that, those two tracks, is the area shown in golden that's the target for tremor surgery. It's called the VIM nucleus of thalamus, and so that's where we target to do surgery for tremor, be it the deep brain stimulation surgery or the focused ultrasound ablation surgery. And we have used this technique to optimize the technique of focused ultrasound ablation, and shown that using this technique, you can be very, very effective in improving patients' tremors, improving their quality of life, while in the same way, improving the safety of the procedure. The key word in our minds is improving the effectiveness while also improving the safety and reducing the risk of side effects that can sometimes come with this surgical operation. And we have published this experience as shown here. The other exciting advance in our field is the use of what we call directional stimulation. And so when we do deep brain stimulation surgery, here the deep brain stimulation electrode is shown, and the target of stimulation is shown to be in the dark purple. And so in the conventional design, you would implant the deep brain stimulation electrode and do electrical stimulation shown here in red. And so it's an electrical field that is around the implanted DBS electrode. As you can see in the conventional DBS leads that we used to use 5-10 years ago, the stimulation field is kind of spherical in shape around the deep brain stimulation electrode. And what that did is it was very effective in controlling symptoms, but at times a small part of this stimulation field could also cause side effects. And so given that need to optimize the shape of electrical field, different manufacturers have come up with this design to be able to steer the electrical field in one directional or the other. So these are called directional deep brain stimulation electrodes that allow you to preferentially stimulate areas that improve patient symptoms while avoiding areas that cause side effects. So again, a very exciting advance in our field that has been a few years in the making and is a reality today. The other exciting advance in our field is focused ultrasound ablation, which is an incisionless treatment for movement disorders. And this treatment is enabled by the use of this transducer. And so this is an open transducer that's shown here. And this transducer looks like a helmet, and it has about 1,000 ultrasound beams that are organized in this helmet shape. By itself, each one of these beams are harmless to the brain, but then when 1,000 of these combine together in a single spot, that allows you to then very effectively ablate brain areas causing patient symptoms. So one good way of thinking about it is this, that if say, for example, you're outside in sun and you have a piece of paper and you keep that piece of paper in sunlight, the paper wouldn't have any effect of the sunlight on it. But if you were to use a lens to focus the sunbeams at a single spot, then you would be able to very precisely be able to focus those sunbeams and burn that paper. And so same way, the concept is that all the beams of ultrasound by itself are harmless, but when 1,000 of these meet at a single spot in the brain, then you can very precisely ablate brain areas that cause patient symptoms. And the modern focused ultrasound leverages MRI imaging with the ultrasound here shown. The MRI is shown here in the big donut-shaped machine, and the ultrasound transducer is mounted on the table. And combined together, this is a very powerful technology that can precisely allow you to ablate in the brain. I have a video which is about 4 minutes long, and I'll run that video and talk to you about what the important aspects of that technology are. And so focused ultrasound
is an FDA-approved treatment for essential tremor and
sorry, the volume came up by itself. And so, as you all know, focused ultrasound is FDA-approved treatment for essential tremor and Parkinson's disease. And this treatment is incisionless, doesn't require anesthesia. It can be done outpatient, and the results of this treatment are immediate. So you do the treatment, and at the end of the treatment, patients have improvement in their symptoms. And this treatment, as I mentioned, is done with integration of MRI. Patients undergo placement of a head frame, shown here, the metallic frame, that allows us to keep the head steady during the treatment. And then we put the ultrasound transducer, shown here, on the patient's head. It sits like a helmet on patient's head, and patients are laying on the MRI table. They're awake and inside the MRI environment that allows us to do this treatment very effectively. And on the back end, this is how the interface that we are working with looks like, where the ultrasound transducer here is shown with these different ultrasound elements shown in green and blue. And we are looking at treatment parameters that include, how many elements are on. So as I mentioned to you, about 1,000 elements are available. And in this case, for example, 978 of those are available for treatment. We look at other parameters, including the skull score, which is an important metric that can tell if someone is a good candidate to undergo this treatment or not. Once we work through the different treatment parameters, then we initiate the treatment by prescribing very low dose of ultrasound to temporarily increase the temperature, shown here in the line diagram, where it shows with the red and green lines the temperature increase at the target for ablation. And so initially we use very small amount of energy to transiently, temporarily increase the temperature of the area of targeting, and allows us to test whether this slight increase in temperature can reduce patients' tremor and can improve their symptoms. And so we then deliver this very fine ultrasound, very small amount of ultrasound energy precisely at the spot, and then do testing to understand how that changed patient symptoms and make sure that patients are not having any side effects. And once we understand that the area is safe, and once we understand that the patient's tremor are improving, then we prescribe high enough dose to increase the temperature at the thermal spot, at the brain spot, and be able to then make the effects permanent. And so first we do the testing, and then we use higher energy to make the effects permanent. And so at the end of the treatment, then patient symptoms improve and they are able to be discharged the same day after surgery. And this treatment has been done in thousands of patients worldwide. The last count was roughly 15,000 patients worldwide who have undergone this treatment, and it has created tremendous excitement and enthusiasm in patients to undergo treatment for their tremors. So I'll pause here, and it gives me tremendous excitement to then invite my colleague and partner, Dr. Danny Roque, who is an expert movement disorder neurologist, has tremendous wealth of knowledge in treatment of hyperkinetic movement disorders. He specializes in treatment of tremors, and I'm very excited, looking forward to his talk about tremors, the diagnosis, potential treatment options, and how to approach your physician. Dr. Roque, floor is yours.
Thank you, Dr. Krishna. A pleasure to be here today to chat with everyone about these topics, because it isn't necessarily straightforward. This is not the kind of thing that anyone teaches you. Anyone teaches you how to really speak with your providers who have otherwise provided you with a label of what your tremor is related to. So I think it's going to be useful for anyone in most walks of life, kind of even just to learn if you just happen to know someone who is affected or afflicted with this condition. So this is just to let folks know what else I do related to this topic. The goals of today, let's start off reviewing the information on essential tremor itself so that we can better comprehend the condition, understand the wide range of impact that it can have on folks in different walks of life, review the ways that we separate essential tremor from other tremor syndromes, which is pretty key and important, what to tell your healthcare provider unrelated to focus ultrasound for a moment here, because I want to approach this more generally and work our way toward the discussion of focus ultrasound, then understand focus ultrasound itself and its role in the management of your tremor. The benefits, of course, the unique risks and side effects associated with it, and then how to approach your neurologist. Certainly could be more than just your healthcare team, really, regarding the possible pursuit of focus ultrasound. And I hope to finish this off by introducing you to the breadth of our team here at UNC. So let's talk through essential tremor itself. So what is it? This is a condition where shaking ultimately is occurring. And with our newest definition as of the last 6 years, we're expecting there to be shaking in the arms, largely interrupting your ability to perform a number of fine motor tasks, often involving the fingers and hands, but it really could be the whole upper limb, so the whole arm in and of itself. It isn't otherwise caused by a better explanation. And this is key because unfortunately we don't have a way to diagnose essential tremor from the perspective of a blood test or an imaging, like an MRI or a CAT scan. These are not tests that give us the answer. We have to put the pieces together. And so we need to ensure there isn't a better explanation. It can involve and often does involve more than the arms, but we need the arms involved to keep the diagnosis in check. But the head can be involved, your voice, the legs, even the trunks or your core could absolutely be involved as well. How common is it? Well, it's estimated to roughly affect 10 million people in the US alone. And just for a comparison, because we may have folks here learning about ultrasound that don't have essential tremor, roughly Parkinson's afflicts up to about 1 million people in the US alone, where 70% of folks with Parkinson's will have some experience of tremor during their disease experience. But that's for comparison. So roughly we say that essential tremor is about 10 times as common as Parkinson's disease. The impact of tremor couldn't be overstated, quite frankly. Often what we ask as healthcare providers is questions about whether it affects your handwriting, whether it affects your ability to eat or drink, if there's any social stigma or embarrassment caused by the presence of the tremor. But often we forget or don't have enough time to ask a lot of other very practical questions that perhaps some of our occupational therapy colleagues think much more often to ask about mechanical use, technology use, so, using a computer, using your smartphone, things of this nature, housekeeping, cooking, even just, regular hobbies that you were used to doing at one point that have gotten exceedingly difficult, if not impossible, to perform. So how do we tell those tremors apart from other tremor syndromes? So let's start with this. There's a little bit of history here, which is that we have taken a long time in the field of movement disorders to try our best to separate different tremor syndromes from each other, and it has not proven easy. And we probably still have more ways to go. But the relevance of separating tremors from each other is that different tremor syndromes respond to different therapies. That includes medications, that includes occupational therapy pursuits, and even the outcomes of some of the available brain surgeries that Dr. Krishna already alluded to. So distinguishing rest tremor, which may seem straightforward at first principle, but rest tremor that can actually intrude on your regular posturing and performance of fine motor skills. Separating something called dystonia, which is excessive muscle contraction, leading from a signal in the brain to the muscles that can be tremulous. Sometimes it's just ensuring that tremor is not being caused by something you're taking or something that you're specifically doing. And I'll walk through these, but we did get, again, some benefits from recent efforts about 6 years ago to redefine essential tremor. But even then, the message is slow to be adopted across the world, quite frankly. And it still is going to require a keen eye to feel that we're getting the label right. Because the label will matter, if at least trying to get it as accurately as possible, it will matter. So first, how do we use the current diagnostic criteria? In order to qualify for essential tremor, for that diagnosis or that label, you need to have tremor in both arms with action. Just meaning that you hold a posture or you reach for something or you're actively engaged in activity with your arms. And notice I am mentioning both arms, and I'm mentioning that this needs to be part of the diagnostic history. It doesn't mean you have to start there, but you absolutely have to have them involved. It could include tremor in other locations, but not required. And then you have to have the arm tremor at least for 3 years before we can sit on that label of essential tremor. Because if you don't have these base criteria, it becomes harder for us to sort this out. We've made assumptions that are not fair to you in the process of coming up with a diagnosis. And again, these are not things that are easily or well adopted because we've only been working with these labels or these diagnostic criteria for the last 6 years. Then I already alluded to the importance of action tremor. So action tremor, here's just some examples here. There's 2 of them. Postural tremor is you hold that posture and immediately you start shaking upon holding that posture, such as grabbing a book, holding a plate or a cup in your hand. And then the intention tremor is reaching. Again, it's sort of more active engagement, movement through something as opposed to holding a posture. But then there are many other tremor types too. Rest tremor, as would be alluded to, you perform nothing with your arms, your legs, but you start to shake that limb, or you start to shake the jaw. You start to shake. The head's a little tricky because if you're holding your head up, in theory, you're not relaxed. So there's still muscle tone there. So we have to be careful how we interpret that information. There's something called re-emergent tremor. And this is what really gets to a lot of our neurologists in the community, who we appreciate the effort they do, but it's tough to distinguish this because it's tremor that is truly at its core rest tremor that pushes through a posture. So if you hold a posture long enough, like you're holding a book, over seconds, it starts to build in how large the amplitude or the size of that tremor is in the midst of that posture, as opposed to holding that large amplitude from the very beginning of performing that posture. So again, a little tricky, but it's really all about you holding a posture, the rest tremor comes through it. So really they're one and the same. And then I mentioned dystonia earlier. There is something called dystonic tremor. Again, a signal from the brain indicating to your arms, legs, trunk, what have you, to hold a posture and actually involuntarily hold that posture. So when you fight it, you can create a jerky tremor along the way. It's not always, sometimes it actually can be quite keep a good rhythm. But at the end of the day, this is the underlying process. It's really about your brain telling your body to hold that posture, even though you don't want to. All right, so how we go about requesting assistance for your tremor? So first, your provider is going to need to collect quite a bit of information about your tremor, understand it well. And if you can help them out by collecting your own efforts, find out if there's any family history of tremor, find out if others may have noticed your tremor before you did, because that does occur in a good number, I wouldn't say any majority, but a good number of folks who come to see us. Because it gives us a better timeline, right? Again, we're using that 3-year timeline to build that history and story for the label of essential tremor. So having that information is pretty key. How long has the tremor now bothered you, right? So there's a very different point here. One is just knowing how long you've had the tremor for purposes of quantifying the time. The other is how long has it really bothered you? How long has it kept you from doing certain activities? And then which specific activities. I mentioned this. And then if you are bothered enough by the tremor inherently, you might be offered medications. So what are those options? In essential tremor, we have a few. None of these therapies were designed for tremor. That doesn't mean there isn't an effort. There is an active effort to change that, but we don't yet have any FDA-approved tremor-designed medications or pills out there. So this is what we have to use: primidone, propranolol. These may sound familiar to the group here, but both of these therapies hold a better than 50% chance of having some tremor reduction. The goal here is it's not a 55% tremor reduction, it's just 55% of folks would respond. For propranolol, 60% of folks would respond. If you combine the two, you actually get a better result than if you just use one or the other alone. Topamax or topiramate, this is a medication that we note as physicians, we see a change, but very often patients don't report much of a change, although occasionally you do, so it goes back to potentially being of use to some folks. And then other therapies that have been tried historically include clonazepam or Klonopin, gabapentin. The use here is not clear, this goes for studies and even across patients who have used them. But again, historically, we may not have had much of a choice. Tricky thing about gabapentin too is that could actually induce tremors as well in and of itself in folks who didn't have tremor to begin with. But again, these fall pretty short of being ideal for really providing significant long-term suppression for our patients. Ask yourself, what are your personal goals going through a visit regarding your tremor and clarifying, rather regarding evaluation of your tremor? First, let's make sure we clarify the diagnosis. If you're doing this with your PCP, seeing a neurologist. If you're seeing a neurologist and you're not clear on it, maybe seeing a movement disorder specialist. There aren't that many of us in the nation, but there's at least a group of us, and folks usually know how to get a hold of us or how to request a referral. And not everyone is in academic centers, and that's another kind of crucial, important point. And then seeking treatment, Sometimes it's about pills. Other times it's about visiting with an occupational therapist. And if you stay tuned to future webinars, we actually have a whole webinar dedicated to this particular topic. There are specific things that sometimes can be quite more useful for specific things you'd like to improve your tremor upon than just having a pill all day long for purposes of general reduction of tremor. All right, so now you've approached this your tremor in this manner. You and your provider have attempted to pursue occupational therapy, have attempted to pursue medication options, and you're really not getting enough of what you're looking for. And expectations are generally reasonable, but they're just not being met. So what do? Okay, so when meds fail in particular, but perhaps arguably even prior to this, there are some surgical techniques available to us. You heard them from Dr. Krishna. There's the so-called traditional thalamotomy. So this is that same spot in the brain, the VIM, ventral-intermediate nucleus of the thalamus. We're working toward burning a hole in the brain. We can do that here with the traditional thalamotomy, which we had many decades of experience as a medical community performing. And then there's also still to this day, without having to open the skull, gamma knife procedures. Then there's deep brain stimulation surgery, the basic concept of inserting wires into the brain, aiming to the same location that we're still talking about, VIM nucleus of the thalamus. And here the wires do the work. You're stimulating with the help of a pacemaker, everything's under the skin, and you're trying to stimulate that part of the brain to interrupt the signal, or so we think, where tremor is coming from. And then the MRI-guided focused ultrasound ablation, which we've already heard about here. Again, similarly, never opening up the skull like in the traditional thalamotomies, but still making that small, precise hole in order to affect the same region. And what's really key and important in all this is this target where we're aiming for is not the origin of tremor. And I couldn't stress this enough. This is a conduit. It's a conduit for tremor. Where the origins of tremor we're still studying, to be entirely honest, but we think they're in other pieces or other parts of the brain, perhaps even the coordination center of the brain, which is a dangerous place to do surgery on. So we're really in a conduit, we're in a relay station of sorts that we are trying to impact so that that signal doesn't effectively get through to the parts of your body impacted by tremor. So just a little bit of a timeline review, just to put all that into perspective. We actually did start performing thalamotomies in the 1940s. And when you move forward, it takes 50 years, roughly 50, 60 years to really see DBS come to the fold from the FDA approval perspective anyways. It was really started in the 1980s and 90s, but nonetheless, that's where we get the first approval. And then coming back to fold here, we have in 2016, we're starting to see the first time approvals for essential tremor using focused ultrasound and eventually into Parkinson's disease as well. So that'll be a nice segue into the focused ultrasound discussion. What is it we're aiming to do? You've heard it a few times, but I'll be more specific here. We are trying to burn a very small, precise hole in this area, this VIM nucleus of the thalamus, so that if it's your right hand that's affected, we're burning the left side. If it's your left hand affected, we're burning your right side. And we hone in those, over 1,000 ultrasound beams from the transducer to heat up this spot of interest, which we use, or we plan this out through the assistance of an MRI scanner and even some CT scan information prior. You're awake for the procedure. Your head is shaven for this procedure. It's necessary to stay awake so that we can test you both for tremor changes as well as any potential side effects that are developing during the procedure, because we get a lot of information from doing just that. The head frame, which we're seeing an older version here, but nonetheless, the concept is there's a head frame that requires, that has to be fixed onto your skull, onto your shaved head. There's 4 points where this is performed, and all of this gets effectively fixed onto that transducer that you see on the bed. I did not mean, okay, sorry, that was not meant to pull up like that, but no. All right, here we go. Sorry. So ultimately when you're, well, actually, you know what? I'm sorry. I take that back. Excuse me. I did want to talk about this. Okay, so to make sure there's no audio there. So again, you're laying down on the bed, performing this procedure, and as you're doing this, you're coming in and out of an MRI scanner multiple times in order to perform the heating process, eventually perform the burning process. Along the way, Dr. Krishna is working through the process, and the neurosurgeon is working through the process of identifying exactly where we should be moving the target if we need to move the target. There's a lot of information we're gathering with every scan. And the energy delivery is being monitored throughout that process as you're in the scanner. And again, we pull you in and out. So you're in the scanner for short durations, but those durations are minutes at a time between the moments that we're bringing it out to do the testing. And the hope is that we're really seeing changes, but the changes we want and not any of the side effects that we'll talk about in just a moment that would indicate that we're just off target. And you can see some of that outcome there. All right, now that I've gone through that. Thank you. All right, so at the end of it, when you do imaging and you take a look, you can actually see areas where we've created that hole. And what you're seeing here is not just the hole, you're also seeing areas of inflammation around the hole, which invariably occurs. When you disrupt brain tissue, it doesn't like that, your body doesn't like that. So it's going to cause some swelling around that area, which will take, effectively weeks to totally resolve. So you can have both benefits, but also side effects that are related to either the area that you burnt or the area of swelling. And these will be really difficult sometimes to parse out without just giving it some time. I already alluded to this. So that the whole point there is we actually still like to call this neuromodulation, because at the end of the day, we actually will heat up the brain first without burning. And the heating process gives us a lot of information before the burn, before we actually make that small hole. So that we can, again, just shift the area that we are heating up to give the safest, but hopefully best outcomes once everything is over. All right, so how well does it work? You'd have to follow this over time, but here's some of the earliest results, which is what got our approval in the first place, that folks who got ultrasound versus got nothing, in the sense of went through a sham procedure, saw, up to roughly 50% improvement in tremor scales, and even quality of life improvements that sustained over the year. When you study this, and these are the benefits there. These are the disability improvements or changes where you're following the blue line is a sustained benefit. We didn't have data on the 12-month really for the folks who went through sham. People end up crossing over. And then at 2 years, we have some interesting and important information as well, is that there was a sustained benefit on those same scores. This one's important too. These are individual lines for individual patients followed like sort of over that 2-year time frame, trying to see how their tremor score changed, what percent change occurred from before surgery or before the procedure compared to 2 years later. There was about 40% of folks who showed less than a 50% improvement after 2 years, but nonetheless at least had an improvement. So, and these are really early results. So I just want to sort of emphasize that we're still collecting additional data, especially as we're getting better at this procedure over time. But still, what are the possible side effects worth talking about? So during the procedure, just from that heating process, just from experiencing that, even just from the burn, folks do experience some dizziness in many instances, can experience a sense of almost floating in the MRI machine as things are occurring. You can also experience nausea, and the hope is that we don't ever get to the point of vomiting, because that inherently is its own process. We have to be careful and thoughtful and quickly get you out of the scanner should that occur. But we're trying to navigate that side effect perhaps best of all. Headache would be a not necessarily infrequent experience, whether during or immediately after. Usually while it's occurring, some folks will feel, if any, this warm flushing sensation over the scalp. But you can also experience tingling and numbness as again, as the heating process is occurring, often thought to be related to being close to the areas of the brain in that area that are related to sensation. But then in terms of longer term complications, right, over time, like what else beyond what's occurring in the procedure, where could we see some downsides? Balance issues come up a lot as a point that we are still in the process of trying to reduce that risk even further. And I'll show you why this is a problem in a moment, but this is one of our biggest concerns. Sensation issues used to be a bigger issue, meaning losing sensation as a result of striking the wrong area or just off target. But we've been able to move away from that side effect quite a bit with adjustments in technique. But nonetheless, speech issues could also accompany some of these complaints, and loss of strength could accompany some of these complaints. So you'll notice that a lot of those end up in this mild category, but you can see the occasional folks who experience this in a more severe fashion. So low risk, but not, I'd be hard pressed to ever say not existent. And then if you follow folks over a year, which really gets to the point of how we perform bilateral procedures, if you follow folks over a year, perhaps the greatest risk that we worry about is what we refer to as ataxia, or coordination difficulties associated with a procedure where historically, and if you go back several years ago, some of the earlier data was telling us that even 1 in 3 people could experience this. We feel like we've been getting better at reducing that number very significantly. But we need to make sure that 12-month time frame doesn't stay as high as 10%, which is what historically it had been. So imagine we don't want folks being discoordinated coming out of the procedure a year later, because at a year we generally think that healing that was going to occur in the brain has already occurred. Certainly swelling is long gone by that point in time. So we're just trying to mitigate that. When it comes to reduced sensation, this again was a previous significant side effect that we were obtaining, and we still saw quite a bit before. It's getting closer to those very low single digits nowadays, but still not zero. Slurring speech and weakness, again, things that can occur during the procedure usually disappear by the end of the full year, but not absent of that risk. So why does this all potentially occur? Well, it turns out we've known this from the days of the traditional thalamotomies, where we opened a hole, and sort of took this physical hot rod down and burned the tip. We have several really important pieces of brain tissue surrounding the VIM, surrounding the target that we want to ultimately burn. This includes areas that are important for maintaining your strength, areas that are important for maintaining sensation, areas that are important for coordination of movement, right? Coordinating the sensation with the movement, with the strength in effective formats. And then if you mess with any of that, you can mess with speech, because you can produce speech difficulties from each and every one of those abnormalities. They may sound a little different, but at the end of the day, it's still some sort of slurred speech or impaired speech. And of course, with all that can come balance difficulties simultaneously and falls. So, this is why all of this comes up, and it comes up in any of the brain surgeries, quite frankly, but it's because these tissues all live right in and around the areas that we want to affect with these procedures. And then, as I started to allude to already, the FDA did approve for us to perform the ultrasound procedure on both sides, but it is what's called a staged procedure, meaning that we have to separate each side at least 9 months, if not 12 months from each other, so we can watch for any potential recovery. If you had any of those side effects, what kind of recovery did you perform at 9 to 12 months, and perhaps to reduce the risk that we inadvertently miss a chance to keep you from falling more often or having complications more often. So even if you had a good outcome, we still have to wait 9 months, because that was how the studies were performed. All right. Can my care team help me find out if I qualify? Sure. Here's a few favorable signs for considering focused ultrasound that you could raise with your neurologist. Your goal is to treat arm tremor, and that even though we are having some increasing data that might tell us we can try to aim for tremor in other parts of the body, right now this is the main focus, and I would argue even our experience tells us it is and should be the main focus. I want to treat my arm tremor. If you want to treat the two sides, then again, just be prepared and be okay with the idea that we're going to separate those at least 9 months apart from each other. And that you are clear, perhaps with your provider, that you have a diagnosis of essential tremor, and that you don't have something that now is referred to as essential tremor plus. So essential tremor plus is still a base label diagnosis of essential tremor, but we've known this for a long time, that essential tremor can come with balance and coordination difficulties, can come with the dystonia I talked about earlier, can come with a number of other neurological signs and symptoms. And why that's relevant is that that may already predispose you to a risk before you ever go through a process of trying to burn a hole inside of that area of interest. So being clear about what your label is. These are things that are favorable signs. And then the concerning signs, is that you already have signs of coordination trouble related to your tremor, which you may have tremor, but I'm talking about the unique additional coordination difficulties. Perhaps your diagnosis is that of essential tremor plus, and that your hope is that you're going to treat predominantly head tremor, predominantly voice tremor, pursuing this option. I would generally say are more concerning signs, and certainly we could chat through them and discuss them, but may not make you the most ideal focused ultrasound candidate. All right, so with that, I'm going to wrap up by introducing our team at UNC. In the efforts to bring focused ultrasound to UNC, and having been open now for a while, is Dr. Krishna leading the effort, myself coordinating efforts inside of each procedure to do all the testing that we feel is important and necessary. This has allowed us to catch really early signs of potential pitfalls of choosing the original target we were going to aim for, making a shift and adjustment. And thankfully, we've really seen the benefits of this approach in terms of just folks feeling like they're keeping those benefits that they wanted from tremor suppression, while simultaneously significantly reducing our own interpretation of the side effect risk percentages that we were otherwise walking in assuming we might have. So that's how we perform things at UNC. We also have, and I'll just sort of finish off with the thought that we have a unique clinic called the UNC Tremor Interdisciplinary Clinic. It is the first of its kind, to our knowledge, at least in the nation, possibly in the world, looking at visiting with multiple providers, myself, Dr. Krishna, one of our occupational therapy colleagues, research coordinators. We have a biomedical engineer who is integrating into the clinic. And with all this said, we're just trying to get as much information and educate our folks who come in. This is really meant to be a session for patients, families, even providers who refer patients to us, to learn everything you can about all the options and even get clarity on the diagnosis that you might be having. And put that in one big script for you to take with you, for you to take to your care teams. It's not our goal here to necessarily try and manage everybody, because that would be probably a very monstrous task, but we want to get the word out. We want people to know, you don't have to be alone trying to identify somebody's specific tremor syndrome, and moreover, understanding what more comprehensive options one has available to them in the process. So with that, just to summarize a few points here, just remember that essential tremor is a syndrome. Separating it from other tremor syndromes is crucial. The treatment that's available should be tailored to you. But none of these treatments we have are cures. Focused ultrasound is now available, and again, can be performed on both sides through a staged procedure. It is quite minimally invasive, especially would be in many senses thought as even more minimally invasive compared to folks who might be thinking about deep brain stimulation surgery as an alternative. We can still neuromodulate by heating things up before we burn any areas of the brain. And there are options. I mean, you can speak with your care team, certainly your neurologist, about seeking out that consultation for whether you might qualify. And I will leave this slide up for now, but open up for questions. And I thank everyone for your attention and your time.
Awesome. Thank you so much, Dr. Krishna, Dr. Roque, for a wonderful presentation. I always learn so much when this team gets together and kind of goes through that. And I know we have got some questions here. So I'm going to start with this one that is in there. And then if you have questions, please utilize the Q&A button and we will get started. Someone wants to know and describe about the painful part of focus ultrasound, i.e. when I know we've been through treatments, we've seen them. The worst part of the procedure is number one, numbing, and then putting on that frame. So this person talking specifically about that lidocaine application to numb for the skull placement, sometimes feeling the sonications can be felt by a warming of the skull. Can the numbing and the skull placement be done under general anesthesia? Can you give some of that, wake someone up once it's done, and then put them in the room? Can you kind of talk about your guys' process to make that uncomfortable part about it is as comfortable as possible, and kind of walk this person through it?
Thank you, Katie, and thank you for this question. That it's a very important question, and it's asked quite often. And we had a chance to think about it as to how to optimize that part of the procedure, because my patients would often describe this to be the hardest part of the day. So a few things that we have started to do to change the course for that include the following. One is that we've started to give this medicine called IV Tylenol that we start before we do any of the local anesthetic administration and such. And so the nursing member who's a part of our team starts the IV, and we start a medicine called Tylenol, which is given IV to help with any subsequent pain. And then we use a local anesthetic ointment to apply at the site for future injections. And so we apply that ointment on the skin with the hopes to reduce that painful feeling even further. And then we inject the local anesthetic. And then again, with the local anesthetic, the technique that we use is called the scalp block, so that we are injecting this to block the nerves again, with the hopes that it will help when we are doing the sonication, which is the treatment part of the procedure, where we give high dosage to then ablate the area of the brain causing patients tremors. And so a combination of all these has allowed us to do this in a reasonable way where patients are not having a lot of pain. The idea of using general anesthesia and being able to wake up the patient and then do the treatment is attractive, but it has some downsides to it. Once you give general anesthesia, the tremors actually go away. And even if you wake patients up, it takes a little while for the tremors to come back. And as you heard from the video that I presented and Dr. Roque talked about, it's critical for us to know how your tremor is doing during the treatment. And so that tremor on the day of treatment is our ally, it's our friend, and we want to keep it there and not lose it. And so we do everything we can to reduce the pain and discomfort. And we've been able to do this in a reasonably comfortable manner, the way we do it.
Awesome. Thank you so much for that. And hopefully that helps to ease your mind on some of the things that you kind of heard of, all the extra steps that this team takes to make it as comfortable as possible. So this next one wants to know how, and I think it's on the screen, how can we make an appointment for evaluation? And then let's talk about, you guys alluded to it. I kind of know this answer because this is a very unique team in this country. You have that specialty clinic. Dr. Roque, you're a movement disorder specialist. It is, like you said, there's not that many of you in this country. I'm sure these patients have all had their own pain points with getting evaluated. While they call you and Dr. Krishna on there, how long can someone expect to have to wait to be evaluated by this team, either directly like this or in that specialty clinic that you talked about?
Yeah, we I'll answer that question, but maybe also answer the other person's question as which I think might be a slightly different, but that's a great question, which is that we have multiple avenues to getting into our clinics, into the evaluation process for the surgical consideration. That includes independently with myself, with Dr. Krishna, as well as requests for this specific clinic. And we really look through the interdisciplinary clinic requests, since it is a very educational clinic. We're looking for folks who might qualify for that versus just asking. And we're a very active referral team, in the sense that we let you know and ask you what your goals are through the process of receiving a referral for you. But we do ask for a referral from any of your providers, even just your primary care doctor, so that we can review it, make sense of it, so that ultimately we're trying to shorten that time frame as much as possible. Usually within weeks to months, to get that first evaluation. And I mean, I'm talking a couple months. And that's just because we've really worked hard to stay available and open to new folks who might want to come in and ask about these options as well as others, right? To kind of maybe have that comprehensive review. With regards to maybe someone in your area, if your area is not our area or near our area, and seeking an appointment, there are a multitude of different options for, I'm going to dare say, lists of folks who offer focused ultrasound around the country. So you can look for those. I'm sure different academic facilities or other facilities. I mean, look for hospital settings, but generally having that option to look for perhaps somewhere closer to home is not unreasonable, but we're happy to help wherever we can.
Perfect. And then there is 2 questions here back to back. Is this procedure focused ultrasound covered by Medicare? Let's talk about the first side. Let's talk about the second side. And then the other person asked about supplement providers, approved by Medicare and supplement providers. Not quite sure what they're asking there, but just wanted to voice it in case you guys did.
No, thank you, Katie. So this procedure is FDA approved and Medicare reimbursed. And in North Carolina, the Blue Cross Blue Shield of North Carolina was among the first carriers to approve it. I think it was back in 2017 or 2018, and they've been supporting this since. And as far as the Medicare supplement, I don't understand the question.
I think they mean supplement, like a second private payers, other payers in supplementation to Medicare, as opposed to, yeah.
I don't know, but we are happy to have you talk to our financial advisors who can help you, guide through this process. The other exciting piece is that the second side treatment is also now FDA approved and insurance reimbursed. And so that's very exciting as well. And then most recently, I think TRICARE also approved this procedure for reimbursement as well. So all the major carriers across the country cover this as insurance approved procedure.
Perfect. And then you just alluded to it. And for everyone listening, this UNC team does a really good job of making sure and verifying all this stuff up hand. So they have an entire team that runs your insurance, make sure, and there's nothing hidden after. So all of that's taken care of on the front end, not the back end. So just in case you have some concerns on that, this team does a wonderful job on that. So there's a couple patients here talking about not living completely local, few hours away. One person's a couple hours away, 2.5 hours away from UNC. So how many trips does someone need to come in locally in order to complete this process? And then if for the day of the treatment, do they need to stay overnight? What does all of that look for if someone is, maybe a couple hours away from you guys?
Yeah, that's a great question. And so we are a very flexible team, and there are few ways where we are able to take care of the necessary assessments, you know. So with flexible, I don't mean to imply that we are not thorough. We are a very thorough team, but we are a flexible team, and we're willing to work around some patients who are not local and being able to reduce the travel burden, because we do realize that travel burden and access can be challenging. So one way that we see patients is patients come to Dr. Roque's clinic, Dr. Roque sees them, sends them to see me, and I see those patients, and then we schedule surgery. So that's one way of doing that. Another way of doing that is patients come to see me in the clinic, and then I send the patients to Dr. Roque's clinic. And again, you know, once Dr. Roque's assessment is complete, then we schedule surgery for the patients. Another way that we have done to reduce the travel burden would be that patients have seen me in the clinic. They have previously seen movement disorder neurologist, and we find it to be a case where we could definitely make an impact with focused ultrasound in reducing patients' tremor. Dr. Roque sees the patient on the day of the treatment, and so Dr. Roque has kindly agreed to come in early and do the assessment with the patient on the day of treatment, and we assess you, and then we do the surgery right after Dr. Roque's assessment. And so we have done a hybrid of multiple different ways, and we are happy to accommodate based on your travel needs. Please let us know as to, you know, what the challenges are. What we want you to know is that every assessment with a different set of eyes is aimed to look at different aspects of your disease process, and making sure that your outcome is the best and the risk of side effects is the least. And so that's at the end what we want, is to have a great outcome for you, and the process can be tweaked in a way to reduce the travel aspect. There are two things that I want folks to know. The common questions are, can I do the CT scan closer to home? Sometimes we are able to do that, you know, with the help of Insight Tech team, we have been able to figure out imaging centers that do CT scans using the specific protocol that's required for that. But the MRI for the treatment, we would like to do here at UNC. The machine that we use is a high resolution machine, and the images that we acquire are very specific for your treatment. And so that allows us to really personalize the treatment to your internal anatomy. And so as I showed in my slides, you know, it allows us to really understand your brain anatomy and do the procedure safely. And so, yeah, I hope this answered the question, Katie.
I think that did a great job. Thank you. I know we talked about this, Dr. Roque, but just in case, so can improvements be seen in the tremor in the legs and feet?
Yeah, the short answer is it can. The perhaps longer answer is I want to go right back to the fact that you should focus on improvement in the arms as your primary outcome for the procedure. I don't know that we have a great answer for why. We don't perhaps see the exact, the same level of benefits that sometimes we'll see, just as an example, from deep brain stimulation surgery, but it's not for lack of otherwise great results on the arm tremor. And it's perhaps it's because there are aspects of the leg that escape. Again, if you recall, we are not treating the source of the tremor, hence this is not a cure. So maybe there's just some of that signal that can escape through other portions of the brain into the legs, into the trunk, into the head. But the short answer is we could. The long answer, though, is that it unfortunately isn't what we should be aiming for improvement upon.
I think that's great and absolutely fair. Added value, little cherry on top if it happens. What side effects could potentially prevent you from driving a car, and how long? And maybe even dive into, if they don't have side effects, how long do you tell people that they need to stay away from driving a car? And then kind of dive into specific side effects that could happen as a result of focused ultrasound that could prevent them from driving a car.
Dr. Krishna, I'm happy to start this one, but I'm
Sure.
sure of your thoughts too. Which is that the side effects, because they could be, as I alluded to, right? They could be balance or coordination related. They could be sensation related. They could be strength related. driving a car is one of we take for granted how complex it is because we get used to it. But at the same time involves every single one of those systems. So if you impair any of those systems, suddenly your reflexes, suddenly your speed of reaction, suddenly your accuracy of what you're trying to do in terms of pushing the gas pedal, in terms of, pulling on the steering wheel, in terms of using a clutch, in terms of, even just, changing gear, with an automatic car, all these things could be impaired in some way, shape, or form. And so it is possible that if you had any of those side effects, that we're going to recommend that you hold off for some time frame until we can clarify that you've overcome that side effect. And I'll tell you, even for folks who come out of the procedures without any of those specific, but come out immediately feeling maybe a little woozy or just something that's off without examination findings of those problems, we could still end up recommending that you take a short while away from driving. And often we do follow up. It's Dr. Krishna who follows up with folks within a week or so of the procedure, where that could be better answered as to whether you could return back to driving. But yeah, I think that kind of covers. Dr. Krishna, your thoughts on?
Yeah, thank you, Dr. Roque. So as you alluded to, in the first 10 days or so after treatment, there is swelling around the ablation site. And so during that time, we would want you to just take it easy and do your routine things around the house and avoid driving. And I typically see patients after 10 days or so. And I'll tell you that majority of patients are feeling great and they could drive. But this is for abundance of caution that we say that for the first 7 days, 10 days, just take it easy, relax, recover from this. And then we have you start, slowly easing it into your activities of daily living. And most patients are able to drive after that, no problem. And imbalance is the main thing that we worry about, as was discussed. And if patients are not having imbalance, then driving shouldn't be an issue.
Awesome. So this person wants to know if you would recommend this procedure for someone that's 81 years old, and maybe talk about, is there someone that's too old, or there actually is such a thing as too young, and maybe you can allude to that, but what kind of goes with that?
Yeah, so thank you, Katie. So let me start, and then I'll have Dr. Roque chime in here too. And so a few thoughts around this are, so if you look at it technically, the FDA approval for focused ultrasound doesn't include an upper limit of age for treatment. And so it's patients who are adults who have this tremor, which is moderate to severe, is refractory to medicine, doesn't include that you have to be less than 80, 85. And so that's one piece of it. The second piece of it, I truly believe that age is a number. And we come across as patients who are in their 80s and who are healthy and doing great, in great physical shape, great mental shape, and are really enjoying their life, to the fullest. And tremor seems to be the main hindrance in being able to do things that they like to do. And in scenarios like that, age limit doesn't come in my mind in terms of doing the treatment. So the key answer for us is whether, and we will cover that in the subsequent webinars, right? And so whether you are in a physical condition that your body will be able to undergo the stress of the operation. Mentally, are you there? Do you have the social support that's required for this? And so those are the kind of questions that we're looking at, as opposed to just looking at age as a number. And I'll tell you that the youngest patient that I've treated with this, and I won't call them the oldest, because in her spirit, she was the youngest patient I've treated. She was 89. And then she came back 3 months after the treatment, and she actually told me that her real age is 91. And so I would love to have someone break that record. And so 91 is the oldest. And so whoever wants to break that, happy to be open to that. So Dr. Roque, your thoughts on this?
Yeah, I completely agree with the premise that age is a number. being frank, and on the other side of that spectrum is we have had 50-year-olds who have many strong chronic medical issues who really aren't great candidates for performing something like this. And so it's going to be a study of your personal health, a study of the degree of tremor that you have, and what you're aiming to get out of this, right? At the end of the day. So I wouldn't, in fact, we just don't use age as an exclusion criteria for this or for the other procedures we offer too, by the way, to be clear. It's, we're studying all of you and not just the number that your age tells us.
I love that, or what the medical records say, that it's an individual plan at UNC based on where they are in their journey. So I'm gonna change this question a little bit, you guys. So if someone had maybe started the process somewhere else in this country, can they, if they would rather proceed with the UNC team, have records transferred to you? Maybe their movement disorder was at another treatment center that has a focus ultrasound, any kind of that. Can they forward their records to you guys for evaluation?
Yeah, absolutely. We're happy to help where possible. We have colleagues in many centers, and I will say this as a general premise, I believe. I think it goes back to the fact that there are 10 million people in the US alone with essential tremor, right? And then you got to throw another 750,000 folks with Parkinson's who have tremor. When you talk about those daunting numbers, there just aren't enough sites. We don't see any of these things as competitive or competition. We are colleagues at the end of the day, and what we want to do is right by our patients and by the patients out there seeking help. So to put it simply, we are happy to help, and we'll respect your decision for privacy. We're happy to share that information with the folks you've seen before. If that's not your preference, we'll work with that too. But we just want to help who we can, where we can.
Love it. Well, thank you so much for staying on with us this afternoon. Right now, there's no more questions in the chat. If you think of something, feel free to call the clinic, join another one of our webinars as we go through this journey. We repeat the cycle of webinars every 6 months or so. So looking forward to seeing you all soon. And for us at Insight Tech, thank you for joining. Dr. Krishna, Dr. Roque, thank you so much for selflessly giving your time this afternoon, answering questions, educating us. We really appreciate it, and hope everyone has a wonderful week.
Thank you, Katie.
Pleasure. Thank you all.